Hi, can you hear me?
Good evening, Doctor.
Yeah, hi,
Yes, we
Shalini.
can hear you.
Hi,
Hi.
somehow my this like the Mac is not saying that you can't support the browser, so I come through the mobile phone. Is that okay?
It's absolutely fine.
Yeah,
Don't
fine.
worry.
Okay,
The
great.
your knowledge is your power.
Oh,
Let the gadgets handle themselves.
I know, I know.
So
One second, let me shut down the fan. Hold one second.
sure, sure.
Yeah, great.
Yes. Good evening, doctor,
So
and
yeah,
thank you so much for being here with us. This is our first live session at Fragile X Society India
okay,
on
great,
Facebook,
great.
and I don't know if I should be nervous or you should be nervous.
Mhm.
Um, okay.
So we are not at.
So
Have you started the broadcast?
yes, the broadcast
Okay,
is
great.
live on Facebook.
Okay, okay, great.
And in case it's not yet streaming on your page, we will save it and I will give it to you for your
Fine,
page
fine,
also.
fine.
So uh, I don't think Dr. Rishikesh Pai really needs an introduction, also for the reason because if I read out all the titles you have, I will spend 5 minutes doing that. So let us begin with Dr. Sab, tell us a little about your work, your passion, what got you into this field, and more about it.
1 minute. I'll just I basically I've been doing IVF for last 30 years now. I was actually Dr. Hinduja's. I used to work with Dr. Hinduja. I was one of the housemans in KM Hospital, and in way back in 1984, Madam had the first IVF baby, and I was always interested in all these new type of things, and it really inspired me a lot. She was a great pioneer. And in 1989, I went to Melbourne in Australia at the Royal Women's Hospital. There, the world's second IVF baby was born, and my mentor was Dr. Ian Johnston, where I learned IVF and came back in '91. And since then, I started IVF in '95. I did a partnership with my colleague Dr. Nandita Valshetkar, and we started the Bloom IVF group, which is now we have six IVF centers all over India in Mumbai, in South Mumbai, at Lilavati Hospital, and in Delhi, Gurgaon, then Mohali and Nasik, and in Navi Mumbai. And then I actually turned towards genetics as well down the road. My passion was genetics, and I started. I went to Chicago. There's the largest genetic institute in the world. It's called the Wallinski's Institute of Genetics. And in 1998, I went to Chicago to learn pre-implantation genetics diagnosis. I came back, I started it, but somehow I was not happy. I was not dependent on genetics, and I was very worried. I said, if there's a wrong diagnosis, so somehow it didn't gel, and I gave up genetics. And then there was a dormancy period, and last year I rekindled my interest. I think everything has a time and space in life, and I think the time or the moment, and I feel that I always can understand when is that moment, and the moment has come for genetics in the world. So this is the moment, this is the time. If you look at COVID infection, the NGS came at the right moment, next gen sequencing, which actually breaks the code of the virus, and it's now become a norm. It can be used for so many aspects of genetics in different areas of plant, animal, human, virus, bacteria, everywhere. NGS is very important. It decodes the genetic sequences, and that came at the right time, just before COVID. So, in fact, the RT-PCR test and all these things have come at the right moment, and also the NGS uh, changed how the world looked at genetics, because the first initial technology was to do analysis of chromosomes by the standard karyotyping technology, but then came the fish technology. So when I went in 1998, I learned the fish technology, but the fish had a limitation because we have 23 chromosomes, and the fish was a fluorescent technique which could diagnose only 11 chromosomes. It could not give us the total idea of all the 23 chromosomes. Then came the CGH microarray technology, which came in somewhere around 2007, 1990, nearly at around 1997, and then came the NGS in 2000. But in its application in gynecology came in very lately in 2013-15, and so the NGS is a breakthrough technology. So this is the newest, where actually the sequence of the base pairs. So gene is made up of a lot of bunch of codons, and these codons have a base pair. So there's a 3-sequence base pair. So each base pair makes a codon. Many codons make a gene. The gene, it makes proteins or enzymes from that codon sequence. And so the NGS machine can actually decipher the sequence of the codon. You understand? So, and then
That's
at the same
interesting.
time in 1993, there was a parallel breakthrough technology that came, which was called PCR, polymerase chain reaction. It was done by Carey Mullis. And that that enabled amplification of various parts of the DNA using a PCR technology. So these two technologies have now come in parallel and they have merged, so to say. And so, and now, so the next 20 years, you will see a change in the, because NGS, what is the NGS advantage? It can sequence many, say for example, my work is an embryo. So if I had to analyze one embryo, in the olden days, I would like to do one embryo at a time. Now in NGS, you can put 92 embryos at the same time in one tube, and the machine can process them at the same time. So it's a game changer, because now, because of the number of tissues that it can process, the cost will go down. Now at present, if it is in the future, the cost is going to go down. So that will give us access. We can analyze genes of thousands and thousands of people, viruses, bacteria, plants, insects, and it can give us more insight into what's happening in the genetic world.
That's amazing. So, I am not a doctor, and I would like to ask you some basic questions. So, tell me that, is it true that IVF and having reproductive problems is still a big taboo in India, or you think people are now quite open to the whole concept? If they are going through infertility, they are open to seeing an IVF doctor, or you think the taboo is still big?
No, they are open now to seeing the doctor, but they are not open to, like, in the US, for example, or even now here, a lot of friends of mine are there. Someone will say, "Oh, doc, you are so good. You gave me a baby." In front of everyone, she'll say it. One of my friends is there. She's very open, but that is not that openness which is there in the Western world is somehow in reproduction. We are very closed about it. So we would, for example, if you go to a party and you have let's say you have a knee joint replacement, you would talk about it. Oh, this doctor is really good. He replaced my knee and all that, and I'm now feeling very well. That openness. In fact, I had done one very top actor couple, and after the baby was born, they phoned me and said, "Doctor, you will never tell our name to anyone." And in contrast, if there was an actor couple in USA, if I had treated it, she would have told everyone, because she would tell her experience so that others will get encouraged by it. You understand? Here, that is not there. So there is some problem when it comes to reproduction, but actually there should be no problem. People should be more open, because I mean, it's not your fault. If you have a problem, infertility problem or a genetic problem, it's not your fault. So even society's attitude has changed now. So I feel that, but it's still, so the access coming to a doctor for treatment is no problem. Telling about the treatment to others is still, like, many times I get phone calls and say, "Doctor, I'm sending you my cousin brother, but please, one request, don't tell him that I undergone treatment with you." Fair enough. That's still,
the stigma is still there.
Yeah, so that inhibition is there, tremendous. I always feel that knowledge and education are two different aspects of life. An educated person is not necessarily a knowledgeable person. You may have a lot of, there may be a simple man in a rural area who will be more educated than a PhD. Because his thought process. So knowledge is something to do with your enhancement of the worldview of your thought process. Well, education is what you learn and you get a degree. So they are not actually synonymous with each other.
That is true. And so in the IVF industry, there are a lot of advances. In fact, every day we keep reading new advances, and there are so many centers and everything. So, what is your take on it? Like, what are the tips for a successful IVF, or what are the things you like to monitor before a couple comes in to go in for an IVF? Do you think we are in India, we are at par with looking into those matters?
I'll answer your last question first. Recently, 2 years back, I got a patient. She had failed 9 times in abroad. She was just from Sudan, but settled in Norway. So she did IVF 3 times in Norway. Then she did IVF 3 times in Denmark. Then she did 1 time in UK. And then she went to her like Sudan also and did 2 times. So 9 failures. This lady came and we in our Gurgaon center we treated her and she took a baby home. So the skill level. So there are two parts of medicine. One is invention, and the second is application. Once you invent something, you apply it in general practice. So in application, no one can beat Indians. We are also great inventors, but we have not enough access to resources, because in invention you have to dedicate your entire lifetime to a particular project. You may not get a breakthrough, you may not succeed, huge amount of money can get wasted. So we get scared to get into invention. Even governments, they have limited resources, so for them the implementation is more important than the invention. For example, if a vaccine is there, it is the invention may be done by Oxford, but the manufacturing can be done by Serum Institute. So that's the whole thing. So somewhere down here, so when a technology comes to an Indian doctor, his application is excellent. You can't beat an Indian or an Egyptian. Okay, there are Egyptian doctors who are equally good. The best application doctors in the world, according to me, are the Indians and the Egyptians. The best inventors in the world are Russians, Germans, Israelis, Americans, British. British inventions. So many inventions like MRI and all have, even IVF, all have come from Britain. So, but this is a global village now. So everyone has their own specialty. So our specialty is to invent, to apply. You do a surgery, superb surgery. One doctor in India, they'll do 10 knee joint replacements in one day. Or IVF, they'll do perfect and set. So we in IVF, for example, so coming to your question, we have become very advanced in IVF now. So like better than, no, I would not say. See, comparisons, let's put it this way, we are as good as anyone else, any good unit in the world. So that's not, but the more important is we are very cost effective. I mean, we are at 1/5 the price. Imagine. So I personally feel when the new ART bill comes in, now the bill is coming into Parliament, and we should open our shores so that more and more foreigners can come in, because medicine, I feel, is going to be a very important earner for us in the future. For just like TCS, now we are BYTE is important for us. It earns us foreign exchange, but also other parts like medicine is also very important part of foreign exchange earning for us. But only thing, we'll have to be more seamless. We'll have to do more infrastructure development. It should be like a bubble where they can come and then they can do the treatment and go back. But I foresee that in the future, as the infrastructure improves and this, we will become better and better, because the infrastructure is what inhibits a patient from abroad to come into India. They go to Thailand, they'll go here because there is a better infrastructure. Here, if they fall sick eating food, they get mugged. Okay, they may get diarrhea, they may get malaria, they may get dengue. So all these things, we need to create more better facilities at the airport as well. So once that is done, I will tell you, hordes of people will come into India. So now coming to you were asking about what are the breakthroughs. So there is something called standardization. So when I started IVF, I was just one of the first 10 people in the country to start IVF. Now there are 2,500 plus nearly 3,000 IVF centers. So IVF has become standardized. So what happens to people like us? our senior, the old elephants who are there. So we had to evolve. So general IVF everyone does. So as I told you, the difficult IVF, when people fail repeatedly, these are the patients we have started getting, especially the patients. So if you look at the women patients who come for infertility, let me tell you that there's some misconception of IVF. 90% of couples, they don't need IVF to achieve pregnancy. So infertile couples, so if there are 10 people who get married, 10 couple, at the end of 1 year, one couple doesn't have a child. So there the incidence of infertility in the general population is just about 10%. Of that infertile couples, only 10 to 15% need IVF treatment. Almost all of them can be treated by simple methods, laparoscopy, hysteroscopy, to see what's there inside, correcting it, giving them induction agents and all. So with that, most of the people, they become pregnant. Only 10% need IVF. And in that, as I told you, majority of work can be done by any IVF center now, equally good. But the biggest challenge, and this is our main moot point of discussion of today's discussion, what is the major challenge? So in the women, there are three groups of different women who come to us for treatment. One, and they are based on the ovarian reserve. We have there are two parameters we use to test ovarian reserve. One is known as AMH, anti-Mullerian hormone. That is normally a blood test, and the range is 2 to 3.5. And the other is an ultrasound test. It is known as AFC, antral follicle count. So in normal women who have a normal ovarian reserve has a range of between 8 to 15 antral follicle count. So we classify women into three groups. The poor responder, where the AMH level is less than 1.5 and the antral follicle count is less than 7. The normal responder, where the AMH level is between 2 to 3.5 and the antral follicle count is between 8 to 15. And the hyper responder, where the AMH level is more than 4. Some of the hyper responders have got AMH levels of 20. And the antral follicle count is more than 10.
Okay.
The classification. Can you hear me?
I can hear you, but I cannot see you.
Okay. So don't worry. I'm talking. There's a call that is blocking. It will go off in some time. So I'm saying that so we classify these into three basic classifications of antral follicle count, and based on antral follicle count and AMH. And the normal responders and the hyper responders are very easy to treat. Can you see me now again?
No, I can't see you yet, but I can hear you.
Okay. I'll just see what is happening, whether I need to maybe come in again, you think?
No, I'm not very sure. Do you want to exit and come back in?
Just see if I can. Just see.
Okay, now I can see. Yeah, you're coming in now.
Am I coming in?
I think your profile is moving.
Yeah, okay.
Yes.
So basically, what I'm saying is, so the normal responder and the hyper responder, in 3 attempts, almost 90% people achieve pregnancy in the normal responder group and the hyper responder group, because they have a lot of eggs. So many eggs. So when we do IVF on them, they get enough embryos, and we can even freeze a lot of these embryos. So we can do repeated embryo transfer, and from one cycle we can get nearly 90% people pregnant after doing 3 embryo transfers. So in the first cycle, we'll get 10, 12 eggs, we'll create 7, 8 embryos, we'll freeze them, and every time we'll put 2 or 3 embryos back. And in 3 attempts of embryo transfer, nearly 90% people will become pregnant. But the poor responder is the challenge. So the pregnancy rates in the normal responder and the hyper responder are in the region of 30 to 40% per attempt. So in 3 attempts, 90% become pregnant. But the poor responder, the pregnancy rates are 10 to 15 to 20% per attempt. And that is the challenge. So most of the people I get nowadays are the difficult patients, because what happens in the olden days, what used to happen, because the IVF centers were very less all over India, people from all over India used to come to us. Now what happens, suppose there's a center, someone in Aligarh, he'll first go and do 1-2 cycles in a Aligarh center. Most of the time, many of them will become pregnant there. the ones that fail, they then come to a main metropolis for
Correct.
a treatment. It's the same thing
Correct.
in cardiology. Now everyone has
Yeah.
a cardiac bypass. In the olden days, only
Yeah.
Bombay or Delhi used to have. Now even Ahmedabad
Yeah.
has got, Baroda has got, Surat has got. So
Yeah.
so we get a lot of difficult patients. We get the poor responders, which are the challenging patients, and the challenge is to achieve pregnancy in these patients.
A poor responder. So, Dr. Sabin, the way you categorize the women into moderate, poor, and good responders, let's talk about those with a low response or a low ovarian reserve or a low AMH. Um, I would say if you have 100 women coming into you for IVF, how many of them are from the low ovarian reserve out
So
of 100?
so initially I used to get, but now I'm like in the olden days it went, I used to say around 10-15% of poor is what now my practice, because there's a bias now. As I told you, I'm the old man of IVF, so I get all the difficult patients. More difficult patients are the poor responders. So in my practice,
Absolutely.
30-40% are poor responders. And let me tell you one thing: most of these poor responders, though, they want baby with their own egg. That is a real, especially enhanced women. Suppose there's a poor responder, you do 2-3 cycles, many of them will become pregnant, but many of them don't, and maybe they need an egg donation or whatever. They don't like the concept of egg donation. Especially, I've seen educated enhanced women. You tell them about egg donation, they'll get really hassled with you. They really,
So,
I get scared to tell them also about, like, you go for donor. So and I would also not like to. So that is another problem which we have been facing, that a lot of doctors would maybe counsel them, okay, why don't you go for an egg donor? But in my practice, the 10% only I will do egg donation work. 90% I'll achieve pregnancy with their own eggs. Okay, so this is a main differentiator, and the new ART bill that is coming in will make it very difficult for egg donation to be freely available in the country. So we will have to go more and more, and then when there is difficulty, then there is evolution. When there is a
that is
difficulty,
true.
you will
Yeah.
evolve your
Yeah.
practice and you will achieve pregnancy with poor responders. Suppose, it's a donor egg is a very easy way out. I mean, the pregnancy rates with egg donation are 50-60% per attempt. In 3 attempts, most of them become pregnant. What's the big deal? So, and it's a fantastic technique. I like the technique. But you can't tell, suppose for the guys now, let us look at the guys. Even if there's a zero count nowadays, we can go through the testes, take the sperm out and do IVF and ICSI and give them a child. So why should we have double standards for women? If they have less eggs, then the first priority is to try to give them a child with their own egg. Na? So it is very important, and counseling is very
Right.
important. So you have to tell them
So
that
my question to you is, I am like a horse with blinkers, and I don't see beyond my vision. So I want to drive this conversation towards the importance of fragile eggs and infertility.
right.
So when you say that out of the women, you have around 30% women with a low ovarian reserve, and of course a low AMH and a high FSH, are we at a point where we are looking into, are they carriers of the fragile X pre-mutation gene? I am
Right.
saying this because with all the science and all the research that's happening, and I'm heading this organization for the last 18 years, and I have seen over 1,000 families whose children have fragile X syndrome. And we always take history. We have a lot of data of women who have gone for IVF, and despite failed attempts, then there's a successful attempt, but the child has fragile X syndrome. So it is kind of medically suggested that 2% of women who come with a low ovarian reserve are fragile X carriers. So is this screening, or is this thought process, um, being inculcated in India, or you think it is still a faraway dream?
So I'll take the last question first, but I would like to go through, because I'll tell you, I confessionally that I met you few years back. I was doing my conference, and in I think Grand Hyatt, and that was in 2019. The not this conference. I think we did one previously also. No, this is the conference we did, and I wanted to see, and I met you at a genetic conference, and you said, "Doctor, I am into Fragile X syndrome." That was I am very ashamed to tell you that I had no idea what is. I knew something vaguely, but I had no idea. Can you imagine a guy like me? I had no idea about Fragile X syndrome. I had to read up, and because what happened is the time when we were in the college in medicine, somehow these were all just coming in technology. So our generation has missed out on genetics. Now probably the younger generation is very easy with the genetics, but our generation didn't have that exposure to genetics. And one of the important things is, like as I told you, when I entered the genetics in 1998 PGD, I was not ready. Now is the moment. So now my mission is, and I'm fortunate enough that I'll become the president of the Federation of Obstetric and Gynec Societies of India in 2022. God forbid, everything goes well. One of my visions is to see that genetic screening is there all over the country, because one, let us say, disadvantaged child that is born, it can create tremendous pressure for the family and a lot of other people around the family, to the country also. So we must be preventive in our campaign. Okay, so that's one dictum, and one of the things that I have in my mind. Of course, as a role of Foxy president, one of my major roles is to see that I reach out to everyone, all my poorest of the poor, all the people in my rural areas. I want to reach out with basic care, but at the same time, so all the time in my mind, I'm actually tussling in the last 7 months that I have been in this COVID, and I have had enough time to think and look within. I have been tussling, how can I create a singularity where I can do everything for that woman in one shot, not only take care of her anemia, not only take care of her delivery, but also take care of her cancer needs, her nutritional needs, and her genetic needs also. Because in our country there is fragmentation. We need to unify all the dots and make singularity out of it. And to create singularity is very difficult. So coming to conversation, what is Fragile X? I would like to say, then I will talk to you about, because unless we talk about Fragile X, and as I told you, I didn't know about it. So let me tell you, if at all there are a lot of doctors also listening, they also don't know what is Fragile X. I can challenge you. If I can take 100 doctors and I can ask them, they'll not know what is the Fragile X.
No, so don't, I always tell you this, don't take this ignorance personally, because the Fragile X gene was discovered only in the year 1991, and that was after you've passed out of college.
Yeah, I know.
And it is showing, so I literally, because I'm all the time speaking to families, I use absolutely non-technical, non-scientific words. So it is like an entity which is showing its true colors, and we are still evolving with the gene. So even when it comes to children, the way it impacts children, the kind of treatments that are available now for the children, there's a lot of research happening. And last year, we successfully launched the guidelines for Fragile X in India with the Indian Academy of Pediatrics. And this is, again, today's conversation is based on only my experiences with families, because I am not a doctor, definitely. I have seen families, and I've realized that there is a lot of hesitation for them to even say, I'm having a fertility problem. And then when they go to a doctor, if the doctor can suggest the Fragile X testing, because there are two reasons to it. If you start IVF on a woman who is a carrier for Fragile X, it brings down your success rate, because they are very poor responders, not poor responders. I would call them very, very poor responders. And the biggest thing is that even if by chance you manage to get them to respond, they can have a child with special needs, which might not be an informed decision for them. So, what I am always trying to propagate, and I'm telling most of the people, is if you see a woman with a very poor response for her ovarian reserve, suggest the Fragile X test to her. You have three advantages in that. Point number one, if she is a Fragile X carrier, it is a choice she has whether she wants to go ahead and use her own eggs or not. Or we can empower her with the information and let her use a donor egg, which is going to increase her chances of enjoying motherhood and the success of the IVF clinic.
Yeah. So I was just wanted, I totally agree with you, but I wanted to make people understand what exactly is Fragile X so that
Yes.
they'll understand. So in very
Yes.
short terms, I would like to say that we have got two chromosomes, X and Y. Besides the 22 other chromosomes, we have total chromosomes of 46, 23 pairs of 22 pairs of autosomes and one X and Y sex chromosome. So on the Q arm, that is the short arm of the chromosome, in the locus number 27, so there is this gene which is a Fragile X gene, which is FMR1 gene, it is called. And normal the gene has got, I told you there are codons. So each gene is made up of codons, and each codon is made up of three base pairs. So CGG is the base pair. There is a one codon called CGG, and normally in that part of the X chromosome gene, if you test in the normal people, there are less than 45 CGG repeats. So if between 45 to 55, if there is an increase in the repeat, it's a gray zone. Between 55 to 200, it is known as affected person, and after 200 repeats, it is actually an affected individual. Okay, so the what does it mean by that? So this gene produces a protein which is very important for neurological development. So if suppose there are more than 200 repeat, this gene gets methylated and it stops producing protein, and because of that the mental development is impaired, and that causes a lot of problems like impairment is there, cognitive learning disorders are there is a different phases that is there. So all this, so the gene repeats are based. Now what happens is that, so if there's a mother and a father is are not affected and mother has got this gene and they have a girl child, then in that girl child there will be genes inherited by the mother, and from the father there will be normal genes. There will be two X chromosomes, one from the father which will be normal, one from the mother which will have this abnormal gene. But when the gene is getting transmitted, suppose the mother had only 70 repeats, but in the transmission that gene can go and become 200 repeats. So the mother may be a carrier, but the daughter may become affected. You understand? But a father carrier, actually, somehow the father who is a carrier, he doesn't transmit. So there is no doubling of the genes when the father is transmitting to the daughter. So there is so basically the in the olden days there is something called karyotyping. So we had to take photographs of the chromosomes and we had to arrange them, and there was narrowing in the region 27 of the Q chromosome, and that's why the name was given Fragile X. But that was a very vague test of testing for the gene. Then came the DNA breakthrough technology, and the DNA PCR test came in, which is an accurate test. So there are two tests which are done: the DNA PCR test and the Southern blot test. Both are blood tests that are done. And but now the newer version of the DNA PCR test is quite accurate. It not only tells you whether there is vaginal, but it tells you also how many repeats are there. So based on whether they are less than 55 repeat or between 55 to 200 or more than 200, you know whether it's a actually affected child or there is a carrier system that is there. In between the 55 to 200 repeat range, which are the carriers, these are the ones who manifest as in the males and the females. So in the male, they manifest as a late onset ataxia. They get tremors. There is neurodegenerative disorder. While in the females, they get manifested as premature ovarian insufficiency. And 20% of these women have got premature ovarian insufficiency as in the carrier group. So overall, if you look at women who have got low AMH, suppose 100 women come to me for infertility and I test them for Fragile X syndrome, 5 to 7% will have Fragile X syndrome. Now, this testing has not been done aggressively in India because we don't know only about this. We are just, the AMH test has just come recently. So now we will start campaigning ki, okay, any infertile person who comes to you, you have to find out what is the cause of the low AMH. Suppose there's a woman who is 33 years old and she comes to me and has a AMH of, let's say, 0.5. Normal AMH is 2 to 3.5. Now her AMH is 0.5. I need to find out the cause of why the AMH is low at a young age. She should have had an AMH of 2 or 2.5. Why she has a 0.5 AMH? So there are 5-6 causes of low AMH. One of them is Fragile X syndrome. The other is thyroiditis. If you have thyroiditis, the antibodies can damage the ovary. The third is an abnormal karyotype. If you are a Turner syndrome, there are certain patients who have got two different lines of chromosomes in their body. One is a normal XX and another is a XO. So that these patients can also manifest as poor ovarian reserve. So normally we can do a karyotype to find out whether there's a chromosomal disorder. We can do a DNA PCR test to find out whether they are Fragile X disorder. We can do a T3, T4, TSH thyroid levels to find whether they are thyroiditis. And one of the more common problems in India is that tuberculosis of the ovary can also damage the ovary and cause low ovarian reserve. So it is very important when a woman who is having a poor reserve comes to us, we must do all the tests to rule out all these things. And so one of the things we need to rule out is a Fragile X syndrome. Now, suppose if she turns out to have a Fragile X syndrome, we need to counsel her then. And we can also tell her. So if she has a severe Fragile X syndrome, of course, 200 times repeat, then there is no question of going in. You can. So now what are the treatments available? Suppose a woman like this is there and she does become pregnant, we can do prenatal diagnosis of the child. So we can either do a chorion biopsy or an amniocentesis, collect the cells and find out whether there's a major abnormality, and if there is, then you can terminate the pregnancy. But that somehow is a negative way of doing it. So we can, another positive way of doing it is that you can do pre-implantation genetic diagnosis. Means what? You can do IVF. So you take the eggs out, you take the husband's sperm, fertilize it, make the embryo, and you test the embryo for Fragile X, and only those embryos that are normal you can put them back. So that's a constructive way of doing it. But one of the best ways that will come in the future of doing it is by correcting the embryo. So we have one way where we have a destructive way. We can terminate the pregnancy. Another way is that we can check the embryos and only put the normal embryos back and discard the affected embryo. But that again is a negative way of looking at life. The third way is we can find out which is the affected embryo and you can correct the embryo. And that correction will be available to us 10 to 15 years from now. This year's Nobel Prize last month went to two women, Dr. Emmanuel Charpentier and Jennifer Doudna. Emmanuel Charpentier is a great chemist from France and Jennifer Doudna is from United States, and they got the Nobel Prize for the discovery of a new technology called CRISPR. And this, with the CRISPR technology, you will be able to correct genes. You can take out the abnormal gene and replace it with a normal gene. So imagine 10, 15 years from now, if there is a Fragile X embryo, you will be able to correct the embryo and then put the embryo back into the womb. So this is the different ways of doing it. And of course, if suppose the problem with Fragile X pre-implantation is that enough embryos there, and that's why you don't have enough technique of doing the biopsy. So many of them, so in those patients you can counsel them for egg donation or adoption. See, people, if they don't like egg donation, they can go for adoption also. That's no problem. So these are the various ways of which we can manage the Fragile X syndrome in the future. But the most important take-home message for all the doctors, patients, relatives. So my vision, what is my vision for the future? The vision is that we should not allow a single child which we can prevent from being let's say intellectually disadvantaged, having a learning disability which is at our disposal. So what are the 4-5 main important problems that can cause this? One is the Fragile X syndrome. The second is the spinal muscular dystrophy group. That, and the third is some amount of congenital adrenal hyperplasia and some amount of inborn errors of metabolism, where you can pick up when the child is being born, you can pick them up. And there is something called expanded carrier screening. There are multiple single gene disorders like thalassemia, sickle cell anemia, cystic fibrosis, Tay-Sachs disease. So the single gene is abnormal. So now what is the new concept is we have got this NGS technology. So with the NGS technology, you can collect blood of the mother and father and you can screen them for single gene disorders. Nearly 3,000 disorders you can screen. So if I want to get now married, if I am a young man and if I have the money, of course, as the technology advances, maybe 10 years down the line, NGS is going to cost you 1,000 rupees. Now at present,
Exactly.
it costs 20,000 rupees. But how many of you buy a Louis Vuitton bag for 1.5, 2 lakh rupees? Or how many of you will buy? So remember, you are talking about your child. If you have a problem with the child, it is going to be a lifelong problem. So if you can screen it, so what is known as expanded carrier screening. This is the new concept that has come already in United States. Many couples who are getting married, they do what is known as expanded carrier screening. So the husband and wife, they test their blood for 300 to 3,000 genes which can cause various disorders of genetics. Unfortunately, expanded carrier screening cannot cover for Fragile X and muscular dystrophy. So the overall screening will be expanded carrier screening plus Fragile X screening plus muscular dystrophy screening. So if I am a person who is affording, I say, okay, please doctor, come and collect my blood and see whether I have any of the genes of these. If their genes are there, we can test the baby in utero, or even we can do a pre-implantation genetic diagnosis and prevent. Prevention is better than cure. You need to prevent the problem. The problem at present is we do what is known as corrective action. We have a child which is born in the family which is affected, and then we wake up. Now you have got a technology to find out whether the child can be affected. You have the money. It is not costly. In 40,000, 50,000, you will be able to test for all the problems in the child. Whether, and if you have that, any of those genes, you can test your child. You can test it before you put it back, or if you don't have the money, you can test it after. And if you have any problem, you can test it early. That is what I want to propagate. People who can't afford, of course, a time will come when the technology accelerates and NGS becomes 1,000 rupees. So even our poorest of the poor will be able to afford. But now, at this present time, people like us who go to a hotel and spend 4,000-5,000 rupees on a meal, these are the people who have to do the testing. They have to do. There is no way out for you. You must do the expanded carrier setting. You must do the Fragile X testing. So, what would you do in the routine way? Yes, if you have a child who is intellectually impaired in the family or in the immediate family, you have a person with learning disorder, you have a child with autism, you have a child with a known Fragile X problem, or you don't care. What does it matter? Just do the test just to rule it out. So these are the various ways of which you can use the new screening technology which is available to you in Mumbai, and see that you don't have a child. It's like insurance. Na? You take an insurance cover. Do you really get? You don't want to fall sick. When I take an insurance cover, do I want to fall sick? No, I don't want to fall sick. But I take the insurance cover. Similarly, when you do this test, we don't want to have any gene to be diagnosed in us, but we want to do it to prevent a baby from being born.
Yes, absolutely. I think that's a very empowering message, Doctor. And if I have you advocating this for me, 80% of my work is done.
Yeah,
Maybe
I'm sure.
maybe
It's like a mission for me as well, because I personally feel now the technologies are accessible to us, especially for
right.
us. Our blessed ones who I always feel that people who can access a Android, they are blessed ones. I always even tell my driver, I said, you are a rich man in India. If you earn 15, 18,000 rupees a month, you're a rich man. because our 1.2 billion people are very poor. So the blessed people, the 100 million who are blessed by God, by our country, who can afford an Android, who can listen to this conversation on this thing, they have to do it. There is no way out for them. They must do it.
And also, doctor, I need a message for other practitioners. I had this experience once when I tried explaining to an IVF doctor to send someone with a low AMH for Fragile X testing, and the answer they gave me was it costs 7,000 rupees. It's too expensive. Now, if we are calculating, forget our meal and the Louis Vuitton, but 7,000 is expensive. What is the cost of one IVF round or second IVF round? And we should, if we try to calculate the cost of raising a child with special needs, your every week therapy is 10 times more than raising a neurotypical child. So I truly need your support to propagate this amongst the entire community. It is going to be a huge service to women, because I am not saying that anyone who knows it. In fact, one doctor once asked me, "Are you propagating abortion?" I said, "No, I am not propagating abortion, but I am strongly advocating the right of the woman to know what she is carrying, and that is not wrong, because she is going to be living with that child. She is going to day in and day out see her child grow at a pace slower than other children. It is her life, and that is ethically and approved. So I am not saying don't have a child with special needs. All I am saying is when we have the technology and the doctors, let the woman be given a choice.
I totally agree with you. There is no question. Only I am going forward. You are too behind. I am saying that I would say the triad, the 3,000 genes plus Fragile X plus DMD plus inborn errors of metabolism. Every child, when is it born, there should be a testing of the urine done or a prick of the heel, and inborn error has to be done.
Yes.
Because you can prevent problems in the child. So these are things that people like us who can afford have to do them. It's a sacrifice. You don't buy a car, but do this. This is very important because your child is very important.
It is.
Not only, and the child can affect not only you, your family, your immediate family, your society. It's very, and as I told you, what is the future? The future is not destructive. Termination is the present answer. Correction of the embryo is the future answer. And correction of the embryo is going to be there. Now, the new CRISPR technology is evolving. Now targeting, what was happening when we were correcting the genes, we were also doing off targeting. Means the CRISPR was affecting other parts of the DNA. Now, more and more precision is there now. In fact, the latest test that Tatas have come out with, the CRISPR, the COVID test, is based on CRISPR technology. So, what I told you, India is an application country. India is not an invention country. India is an application country. Once the technology comes here, it will spread like wildfire. And let me tell you, 10 years from now, Fragile X will be a routine. It will be a routine technology.
That will be
testing every patient routinely for Fragile X.
I will retire. When you start doing that, I will retire from my role. I think I have earlier retirement than you. You have a bigger goal than me.
But, I would like to point out to you, I was reading on the internet, and after Downs, Fragile X is the most common disorder in intellectually disadvantaged children, which is quite a eye-opener for me as well. So, we are now, what are we? The new technology that has come in, that is non-invasive, and I would like to tell this technology also to all of you, who are listening. This is known as NIPT, non-invasive prenatal testing. This is a new technology. All pregnant women, the biggest problem in pregnancy is Down syndrome, which can be trisomy 18, 20, 21, and now also put it in your mind that there can be a Fragile X also. So, the NIPT, of course, can't diagnose Fragile X, but at some point in time, it will diagnose Fragile X also. So the NIPT technology at present is you just collect the blood of the pregnant woman at around 11-12 weeks, and you come to know whether your child has got these three main disorders, that is chromosome 18 to 21, trisomy 18, 21, and 19. This is known as the Down's syndrome complex, and this can be easily diagnosed. So you don't have to do chorion biopsy, you don't have to do amniocentesis, because the other markers that are there, like triple markers, double markers, ultrasound, nuchal thickness, are not accurate as the NIPT is, non-invasive, and it is very affordable now. Within 15,000 rupees, you can do an NIPT, on your pregnant wife. So you should definitely go for it.
Right. No, absolutely. I think your total approach towards the whole thing is it's very positive and very conducive for the future. Like you say, why go in for a destructive approach towards a woman? Let us try and go with the PGD, and people who can afford it, of course. But I think the biggest take-home message is having the awareness that such a condition prevails. It is not phantomized. It's not a story. Such a condition does prevail. And when we are growing so many IVF clinics in number, I want everyone to realize that this can also be one of the reasons if your IVF is not being successful. Let us look at it from that angle. From the angle as a clinic, if you are trying so hard on a low ovarian reserve woman and she is not going to respond well, it is better, before we waste that many cycles, if she gets the right genetic counseling, she gets tested for Fragile X, and at an earlier stage, she's given an option of a donor egg. Because otherwise they go through 6-7 cycles, and it is frustrating. It is bringing down the success rate of the IVF clinic. And as a woman, as a couple, it is absolutely very distressful for them to go through the whole cycle. So I would say that whenever a woman is there who has a low AMH, a low ovarian reserve, and you've eliminated all the other causes, this test is actually an empowering tool for the clinic, for the IVF center, for the woman, for the family, for the future, which should be administered at that point.
Agreed. Totally agree with you that it's an important test, and by default now,
yes,
which is started doing it, and it's very important to do it.
And Dr. Saab, what are your future plans for the genetic clinic?
Hello.
Of
So
course,
it's I feel that as I've told you that when they come first and they have a low MH. So another thing also very important for low MH people, and this is a little bit tangent, but people should know that there is something called oocyte freezing also that is now available.
Right.
So a lot of professional women are there who have for some reason or other are not getting married. So they must freeze their eggs before the age of 35, especially if the AMH is starting to fall. You must freeze your eggs. And if after 35, you should freeze your egg, irrespective of the AMH. But many people, many of my friends are advocating freezing at even 30, because earlier you freeze the eggs, the better is the quality. So even at the age of 40, you can have those. But the default thought process should be that if you have a low AMH, you must do a Fragile X to rule out that 5% chance of having a genetically abnormal child because of Fragile X. Suppose you come to know you have Fragile X, you can still try for the child, and you can do the test antenatally to check it, or you can do a pre-implantation genetic diagnosis before you put the baby in. And if suppose 1-2 cycles you don't achieve pregnancy, then you can, rather than keeping on doing the cycles, you can go for an egg donation cycle as well.
Exactly. That is where
it empowers you to take more rapid decisions, because having a child is not only having the child, but having it at the right time. That is also very important. Having a child at the right time is as important as having the child itself.
Yes. No, that is exactly the point, doctor. Like, for example, 4 years ago, I met a woman who was 28 and she came to me with a 2-year-old boy who had Fragile X syndrome. And like it's a routine, we take history of pregnancy and siblings, etc. She told me that her older sister, who's 33, has reached menopause. And it was a red flag. I said, do you want a second child? She said, yes, but not now, after 5, 6 years. I said, you please go back to your hometown and go to your doctor and get your eggs frozen. I have a feeling you will reach early menopause. She calls me after 6 months crying because she reached menopause and she could not freeze her eggs.
So no, it's very important. What you are saying is very important.
Yes. So we are really working towards the genetic counseling and accurate genetic counseling. And we at Fragile X Society of India say we are always available. We have many doctors who, if the patient is in a fix, they will tell them to contact us and we help them with our examples. We connect them to other families who have been in their shoes to empower them to take the right decision, which is a very important thing.
Yeah, so it's very important to all the time keep clued in, and especially my advice is that anyone who crosses 30 should at least do one screening AMH as well. To see what is her ovarian status. Suppose the ovarian status is low, then one can then go for more. So AMH can be a good screening method for your own status. Okay, what is my AMH? It is good. So that I have a proper good ovarian reserve. My fertility is good. Okay, so that by default we know that then at least Fragile X is not connected with that group of people.
Correct.
So and AMH is quite easily available now. Doesn't cost about 2,000, 2,500 rupees. Some people labs do it at 1,500 as well. So it's not a very costly test. As I told you, as the number of tests go up, the cost of a test goes down. And we must use we must use the power of testing. See, look at what is COVID all about. How do you control COVID? Today I saw that the number of cases has fallen down to 40,000, which is a great news for India. It is by testing. Same way, you have to test and bring the genetic disease down. Because one point I forgot to tell you is that the incidence of Fragile X amongst males is around 1 in 4,000. And between 1 in 2,000 to 4,000, you will know better. But unfortunately, I'm sure the statistic is not that great in India because we are not tested only. Because we don't know. See, we don't know much about it. No. See, the problem is that the guy. So one more point I want to make.
Sure.
See, point I wanted to make, and this is a very important point. And if there are any doctors this is one of my goals of my presidency in the future, is to take the history of the family. This is a big problem in our country. We are so busy that we miss out on one of the most important parameters of the disease, and that is how many in your near family have the disease, how many in the near family have the cancer. History of cancer in the first relatives and all. That can help us to test for cancer genes, or we can be more aggressive in checking for cancer in our patient. How many of them have got history of autism, intellectual impairment, difficulties, neurological problems? So this has to come as a default in our history taking. This is not there.
Exactly.
Though we are taught how to do it, but we don't do it because I don't know. Somehow things are a bit. So we need to change that. The history is very important for cancer as well as for genetic disorders.
And I think now you are changing history because with your practice and under your great supervision and the new genetic clinic, will you tell us a little about a new genetic clinic you are going to launch soon?
Yeah, we have already launched it. We have an NGS system and we launched it to do the screening of our embryos. We have got what we do is we do pre-implantation genetics. We also do NIPT, etc., etc. But I'm not the only one. There are a lot of clinics now in the country that are doing it. But the technology is more important to tell that. So we do the testing of the embryo. So there are two different indications for testing. One is history of genetic problem in the child, or in the first child, or in the family. as about Fragile X or thalassemia, sickle cell. So we will do IVF and we'll take the embryos biopsy and then test it using this NGS technology which I told you about. So we can do single gene defect analysis. And there are a lot of other patients who have got repeated IVF failures, and they are because the embryos are genetically abnormal. They have got trisomy
Right.
18, 19, or
Right.
21, 13. So in or trisomies of X or Y chromosome. So in these patients, we test the embryos, and the embryos that are abnormal, we can pick them up and we can transfer only the normal ones. So this is known as pre-implantation genetic testing of aneuploidy screening. So this can
Okay.
so these are the two techniques that we can do. Obviously, in our country, the sex detection is illegal, and if you can do it, you can go to jail for it. So there is out of question. And I'm telling this to all your audience because it's a government of India thing that if people should know that there is no difference between a boy and a girl. So because genetic test in the olden days were misused for sex detection, and now of course due to regulation there is an imprisonment also. Even if you ask for a sex detection test, there is an imprisonment. So be careful, and just there's no difference between a boy and a girl. So coming back to our discussion, so we can do genetic analysis. So I do genetic analysis in our lab, and we also do non-invasive testing as well. And so there's a new technology which we have brought in, wherein without touching the embryo, by collecting the culture media around the embryo, there's a DNA in it. We can do analysis of the embryos and find out abnormality without actually taking a biopsy of the embryo. So that technology also we have,
Wow.
especially in patients with repeated IVF failure. I get patients which
Right.
are got 4 failures, 5 failures. So many of these patients have got abnormal, genetically abnormal. So we test, suppose there are 5 embryos, we test them. Only the normal embryo can be put in, and we can achieve
Absolutely.
pregnancy. Or we can
Yes.
even, there are
Yes.
many patients with repeated miscarriages also. So in those patients,
Right.
5 miscarriages. So
Yes.
in those patients
Yes.
also, we can offer them pre-implantation genetic testing for aneuploidy. So all these things we
In
do in the
fact,
lab.
having a history of miscarriages is again an indication of being a fragile X carrier.
Right,
But
right.
I'm
So,
so
so
happy to have this conversation with you, Dr. Saab. And this is the first live session Fragile X Society of India is having from Facebook. And I think it's been the most empowering session,
thank you.
definitely. And
Thank you, and
is
I
there
must appreciate Shalini. You have been a dedicated person,
no,
dedicated to this line, and it's very creditable. And people,
no,
you have made
thank
so many
you,
people
thank
aware
you.
of the fragile legs, and I hope that this movement. So my request to you is that not only that you drive the fragile legs movement, but drive the genetic movement also around it. Because
Yes,
as I told you, that I believe in the power
yeah,
of one, unity
yes,
in thought, unity in
yes,
screening. When I want to, if a patient, a woman comes to me,
yes,
I want to holistically treat her not only for hypertension, anemia, diabetes, but also for her genetic problems and her menstrual problems, her infertility problems, and her cancer problems,
absolutely.
and her
Yes,
menopausal problems, and her hormonal
yes,
problems. And her most
yes,
important, another big problem which we have totally missed out in India is her mental status. We have totally, we don't look
yes,
at a patient with the mind at all. It's a problem. We just look at them physically, we don't look at them mentally. So
yes,
the mental stress
yes,
is tremendous on a woman. So these I my mission and vision of life is to bring all these parameters together into one single unity of work and treat the
absolutely.
woman in that direction, for
Yes,
and from A
yes,
to Z, from the richest to the poorest. That is the challenge. That,
yes,
and our country is a big country, but we will achieve it one day. Maybe if not in
we
my
will.
lifetime, I'm sure in your lifetime at least.
No, 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 no. I am retiring before you. We are definitely going to achieve it. And I'm sure everybody who's hearing this live session, we are going to save it. And Dr. Saab is going to have it on his page. Please feel free to get back with any questions if you may have on fertility, on Fragile X, on Dr. Payal's vision. And we really thank you very much, Dr. Saab. Thank you
Thank
for
you.
being with
Thanks a
us
lot
today.
for having me here,
Thank you.
and I'm really grateful. And I hope that a lot of people have learned from today's session. And God bless
Yes.
everyone. Thank you.
Yes. Thank you. Thank you.
Thank you. Bye.
Bye.